This is the PowerPoint we'll get through today, and there is a prep for next week, and remember that we've been working on Mod A all semester. Schizophrenia, we did, and then that communication lab that went in the afternoon with that. New Day, we talked about depression, respite, we talked about Tifa Snow video and stuff. Bipolar was Miss Daniels at BMU, but I'm not sure exactly if she got through what she wanted to, so I'm going to whiz through that next week. So don't forget about those things. And I have uploaded all of the videos that I have used, like the Ryerson, the Tracy Marks, some extra Tracy Marks on bipolar, and something on schizophrenia. So you need to watch that stuff before next week, because we're going to do a brief review and then we're going to work case studies, okay? And what else? The drug list. So those cards y'all been doing that you always think is busy work is half, I know you did, half of the meds that you know that are on your drug list for this test. So you've already learned some of them. So pull those sheets that I know you still got and start working on your meds. And did anybody go to respite with Miss Wilford in here? No, other class, okay. All right, awesome. So we're going to talk about drug abuse today, and very prominent problem in this country. Biggie right now is opioids, and medicines, prescription drugs are being used. We're working hard on that. They, of course, went too far the first time, and cancer patients weren't able to get the dadgum meds for pain, but we're evening out now. Government always seems to do that. But I wanted to start off talking a little bit about a little A&P. I always like to talk about the patho behind this, everything, because that helps you remember. And for when we're looking at drug and substance use disorder, the brain has different areas where different things happen. Y'all know that from strokes, there's vision, sensations, all these things. Here toward the thalamus and the medulla, up in the brain stem and center brain, there are two areas that kind of get real close to each other. And it's this pain pathway and this reward center. Now the pain pathway, when we give patients opioids or whatever that affects their pain, they feel better, okay? But because that reward center is sitting up there, they also get a little, ooh, that felt good. I like that. Because what the reward center is, it's an extra place in there that says, you need to keep doing things to keep your race going. Your human beings need to procreate. They need to drink. They need to eat. They need to do those things. So there's a little area in here that when we do things that make us feel good, it releases in neurotransmitters, like the endorphins. When you get that, some people get that runner's high. Never happened to me. But it releases endorphins, and it makes people feel good, and they want to run again. I don't know why. But, so the problem is that with abused drugs, that reward center is hit. And that's why patients with addiction problems, it's not just a, suck it up, put on your big boy panties and let's just quit this and let's move on, or you need more willpower. There are actually things going on in the brain that increase addiction and make it harder for people to detox and quit using their substance. So this pain pathway and this reward and memory pathway up here, when we give patients pain medications in the hospital, unfortunately, that's how a lot of people got addicted to opioids, is because we didn't really understand the all that was there about, or let's see, we didn't understand the addictive qualities of these drugs, and they would send patients home with 30 or 60 Lortabs. They had a tooth extracted. I can remember going to the dentist and having a tooth pulled and got sent home with 30 Lortabs. I was a teenager. Of course, my dad, the physician, snatched them up and gave me maybe one the whole time. But we didn't understand that that was not a good thing. And also, patients didn't understand how to use them. Not good patient teaching when they left. I had a friend whose teenage sons were at the lake, and one of them got hurt, went to the ER, banged up his leg, didn't break anything, but had a lot of bruising and trauma. So they sent him home with Lortabs. And the brother, who was 2 years older than him, maybe 20, 21, Mom couldn't get up with him, and with the one, and she kept calling, and finally the brother answered the next morning, and she's like, how's your brother? He's fine. He's been sleeping ever since we got home from the emergency room. And she said, well, y'all been home over 24 hours. What do you mean he's been sleeping? I've been giving him those pain pills every 4 hours like it says. And he didn't understand what PRN meant. So brother had been asleep for 24 hours. And that's a good way to lead to addiction. You know, it's the wrongful use. When we give patients pain medication postoperatively, the majority of patients use that pain medication until their pain is gone. And then they'll say, I could take something, you know, a couple of Tylenol would be fine. And hopefully they will home on that. But if we do send them home with pain medicine, they should only have about 72 hours worth of pain medication. And very implicit instructions on how to use that. And if they're still having pain after 3 days, then they need to go back and see the physician and see what's going on. So, but there are patients who are more susceptible to addiction. We'll talk about that. And when that reward in memory gets hit, you know, they do misuse the drugs, can misuse the drugs. Let me go to the next slide because I lost my train of thought here. Okay, so addiction is defined as a compulsive use of a drug. They will reuse and use the drug no matter what consequences have been there. So we're going to talk about some other things that happen when you use a drug over and over again. And the addiction part of it is control, no limit, it's compulsive behavior, and they hit that reward. You ever had patients where you're giving them an IV opioid and they'll go, you can push that faster if you want to. It's because it hits that reward memory center and it's like, oh, that's, you know, gives them that warm, pleasurable feeling. But we know it can also drop their respiratory rate. You know, heck, we all want to feel good. But compulsive behavior and use is addiction. Now, these drugs, common drugs, heroin, cocaine, nicotine, alcohol, they hit different areas of the brain. And they create behaviors from those different areas that they hit. With cocaine, those patients get further up into they sometimes get over to the visual and the sensation, and they can develop compulsive behaviors, pacing, nail biting, things like that. It's because of where these drugs go in the brain. So addiction and another term called dependence are very closely related. Addiction, remember, is that compulsive behavior, and it comes from this reward area up here. Dependence is coming more from this pain sensation and more from the thalamus and those long nerves that, work with this, because it changes the way the body responds, and the body gets used to having that medication. So that when you don't have that medication, the body's going to tell you about it. It's why you have withdrawals. Why, if you have been drinking, you might, socially for a little bit, but you've had several days and you stop, your body's going to go, oh, wait a minute, I was enjoying that. I want some more. Because it's gotten used to it. Okay, that's dependence. So those two are closely related. Now, there is a cycle of addiction that most people experience some type of emotional trigger, of stress, a trauma, feeling pain, just something that gets their usage of their substance started. And it'll start stimulating before they've taken the drug, that reward and memory area. They think that area has a lot to do with cravings and why it is so hard for addicted people to get off of their substance. Because they'll start wanting it. Their body will start saying, hey, remember when we did this? It was really good. Do it again. And so, again, most people have a ritual they'll go through. It may be music. It may be certain people they did drugs with. And those kind of things can also, especially they see it with people that use meth. Because usually if you're a heavy meth user, all your friends are heavy meth users. So if you see somebody that you used to do meth with, those triggers will start, and you'll start having some cravings. But they'll go through the ritual, they'll use, and then they'll feel guilty. No, this is not good for me. Some people feel guilty, some don't. Depends at what point you're at. My little mouse up here is kind of a explanation to help you understand how this is addiction, is compulsive behavior. This little guy had an electrode placed into that reward memory center in his brain. And they had some feel-good stuff up there, I don't know. Gave him a little shock, a little something, and it felt good to him. So he developed, after a few hours, all he did was go over there and hit that little button again. Hit that little button again. That felt good. They put some food in there. Didn't want it. Put some water in there. Didn't want it. Put another little mouse in there. Didn't care a thing about it. So he'd go over and hit that little thing. When they moved that electrode out of that center, that did not happen. So you see that addiction has a very strong chemical, physiological, pathological source to it, that it's not just about getting your willpower better. It is very difficult to undo these addictions. Now, there's some other terms let's look at again. Abuse. I always think of this as college kids, they go off to college for the first time, and hey, I got some freedom. They're going to be influenced by their peers. They're going to go to parties. Didn't take me so long to realize what was going on when my children never had class on Fridays, but they never came home. I'm like, what's up with that? You're not in class, come on home. Mm-mm. Partying starts on Thursday night at Alabama, in case you didn't know. So they didn't want any early morning classes on Friday. But they've all graduated. Nobody's, addicted to anything that I know of. I got doctors and nurses, and, they're doing well. And that's what most college kids do. They realize that mom and dad ain't going to pay for this party time. And if it's, when the grades start getting affected, that kind of eases on out of there and they get serious. But we do have people that go to college and end up, with a serious abuse problem because they're affected by their peers and the culture and everything that's going on there. But that's mostly just being abused. They're just using the drug and abusing the drug. Now remember, dependence means that I have use this substance enough that my body now is expecting it. So when I don't give it to him, I'm going to have some kind of withdrawal. And we'll talk about specific ones for different drugs. Tolerance is a third thing. That means that not only is my body expecting it, but I now need a little bit more to get the same response from it. Like an alcoholic who comes in, a chronic alcoholic, and you take their blood alcohol level, and it is 5 times what you would expect them, they should be laying on the floor out. And they're walking around because they've got that high tolerance. They still got all that in there, but their body is now tolerant of that. It's why when we have patients who have addiction problems with, maybe they're on 20 Lortabs a day, they've gotten addicted to, and that's where they're at. I had a patient that had 40 a day he was taking. I don't know how he was breathing.
How do you function?
I have no idea, but he walked in there. Walked in. But, so, if they are in a wreck or have serious, breaks or some type of surgery, and you walk in there with some hydromorphone, they're going to laugh. They're going to wail and scream because they're still going to be hurting. It is not going to do them any good. You are going to have to adjust your pain medication for those patients. Nurses can have problems. Oh, they're just drug addicts. They're just drug seeking. Well, let's say you lay up in the bed after a car hit you and your pelvis is crushed. That's not the time to try to get them off their substance. We got to help their pain because people don't heal well when they're in pain. But once we get that under control, then we're going to start trying to get them off of their substance and wean them down as we go. But that can be a real problem. And a lot of times that is, you don't know, the patient's on maybe Lortab every 6 hours at home, and you just are not understanding why your pain medicine is not helping them. All right, so it can be physical, that dependence, but it also can be psychological, especially with CNS stimulants. Stimulants tend to, as you're withdrawing, coming down from those, have a crash. These patients, cocaine, meth especially, is really bad. They will start to feel a depression and just this crash feeling, and they will retake the drug in order not to have that, rather than I want to get, back, have another high. They will retake it to keep from having that crash, and we'll talk a little bit more about that. All right, so another concept or word is intoxication, and that's just use of any substance. I know we usually think of people being intoxicated alcohol, but anytime you have a substance on board, you are intoxicated with that. And if we want to change your behavior, we stop giving it to you. The drunk that he stops drinking and he'll fall asleep and then wake up. But it does, people respond differently, especially to alcohol. You probably all know somebody who drinks a lot, and they'll get real angry, real defiant, and want to fight people. Or they get real sleepy, or they get real seductive, or they get real, it does lower your inhibitions. So those things that maybe you normally wouldn't do may come out. But you stop the substance they're taking, and that behavior will stop. We will talk about different medications and detoxing on it, what kind of behaviors you'll notice, and withdrawal, and how to support them. But I will tell you that alcohol is one of the few substances that you can actually die from withdrawing from alcohol, because the alcohol is a CNS depressant, right? Although sometimes we get real happy when we first start drinking it and we think it's a stimulant. It is a depressant. And when you are detoxing or coming off of an intoxication, you will have, especially chronic alcoholics, this is where this really can happen, they will have a rebound stimulation of the CNS. And that's where these DTs come from. So when they first start having those withdrawals, a chronic alcoholic, they'll get very anxious and pacing and, you know, have a lot of anxiety and tremors. And then depending on when their last drink was and how much they drink, they could start now having that CNS stimulation, which will involve the seizure, tremors, the DTs, delirium tremors. They can have hallucinations. They can have seizures, go into a coma and die. So you don't want to take all the alcohol away and lock them in a room and say, go for it, you know, dry out. Because if they're chronic alcoholics, they can actually die from that. So we're going to talk about what do we do with that. You know, how do we support these patients? Because you have to support, if you have a chronic alcoholic who's decided they want to get clean, you have to support that withdrawal. You can't just say, okay, no more alcohol, it'll take a couple of days, good luck. We got to support them as they're going through that. We'll talk about that in just a minute. So, tolerance is a need for more to get the same effect. Dependence is where our withdrawals come from because our body has gotten used to it. And they will experience changes in their body reactions if they start not to use a substance. And our DSM calls drug dependence, or actually that should be drug addiction. Addiction is that compulsive behavior. An addict will have 3 or more of these in a year. And if you are addicted, you are going to have tolerance and you are going to have dependence. But you can have tolerance and dependence and not be a drug addict. Now, who do we give pain medicine to? Cancer patients. They certainly develop a tolerance, and our doses need to go up, and they certainly develop dependence. But technically, they do not have compulsive behavior. Okay, we are not, and that's what addiction is a compulsive behavior. So, and these other things fall into that also. What causes addiction? You've seen a lot of things about addiction, and you know, there's a lot of things that go into it. It's not one thing. You know, we certainly have genetic component where, especially men, if you have alcoholism, your children, especially boys, are more at risk for alcoholism. But there's also a lot of alcoholics out there with no family history whatsoever. Personality, they've seen that a lot of times addicts have low self-esteem. They use their substance to make them feel better, to deal with their stress. That's used a lot when we were in New Day. I don't know if any of the groups talked about, you know, what kind of things do you do to help relieve your stress or to cope with problems. And a lot of times in group they'll say, I smoke weed, you know, or I drink. And yeah, that works, but then when you're done doing all that, everything's still there. So, but that is one of the other things. There are persons that have more likelihood, they have maybe an addictive personality. Why is that going the wrong way? Stop. There we go. Button wasn't working. Of course, peer influence. Children are greatly influenced by peers. And there was a study, kind of old, been 10 years, but at that time there were over 50% of children less than 12 years of age had drank alcohol. Horrifying. And I bet now it's more. Or have smoked weed, or have, it's pretty much out there. Culture is another thing. American Indians tend to have an increase in alcoholism. Well, we know now that they don't metabolize acetaldehyde as well. So they get drunk a lot faster. That is a physiological thing.
I mean, do they know the reason why they don't? Or just...
I don't know that. They might, but I don't. The Italian culture, their children drink wine from an early age, 6, 7, 8. You would think, oh, I bet they got a lot of alcoholics. Nope. We have a much higher rate of alcoholism in the United States.
That's my biggest thing, because I had a friend that moved over there, and I think they can start drinking alcohol at 16, I think, like beer and stuff.
Like go buy some or something, yeah. Well, they use it with their meals to enhance the flavor of their meals. It's not, now this may be changing as cultures change, but, in America, we use it to party, to go to ball games, to relax, to socialize, to do, alcohol is a big thing involved in our social lives, as well as, wine enhances the flavor of food, but there's so many other things that it's used for. We have a much higher alcohol rate. I mean, unless you're just strictly going to church parties, non-Catholic. And I'm Catholic, so I can say that. Then you're exposed to alcohol a lot everywhere you go. And it's one of the big problems when patients go to rehab. They detox, they get off of it, they go through all this stuff, they come home, same stressors, same parties, same friends, same jobs. They gotta get, you can't just take all the alcohol out of the house, because it's everywhere. So they have to learn to deal with that. And that can be pretty hard for them. So we're going to talk about some of these. Alcohol, meth, cocaine, hallucinogens, some other ones, nicotine, of course opioids, caffeine's a biggie. Nobody got there's a Powerade. How much caffeine you got in there, Kim? I know, Jane. Does the Dr. Pepper have it listed? They're supposed to have it listed. Some of them hide it where you can't see it. But a lot of those drinks have 120 milligrams of caffeine. Your coffee has about, and Pepsi's have about 80 to 90, I think. Coffee has less, if I remember.
A lot of people are addicted to coffee, believe it or not.
Well, absolutely.
And energy drinks.
Caffeine,
Energy drinks.
Energy drinks. Oh, yeah. I used to have it written down in here. Daggone. But the US FDA or whoever says that we should limit our caffeine to 200 milligrams a day.
Oh gosh.
Oh, yeah. And those little 5-hour energy drinks, they got about,
I use those. I work at night. I gotta stay up.
Oh, yeah. I guess I would have to. How much? Do you know how much caffeine's in?
I don't even pay attention to
The
it.
energy drinks have like 250 to 260.
The energy drinks? Yeah, because what they do is it'll say 120 on there, but then per serving,
Per serving, which is 8 ounces.
and they'll have 2 servings.
Not
in it.
even enough.
Yeah. So you've blown it off the top right out of the cake. And most people will take, they'll have a slump in the middle of the morning, get an energy drink. Then they'll have a slump after lunch, get my energy drink. Then I gotta go home, I need to stay up a couple hours to get my energy drink. Now we bottled up 600 or more milligrams of caffeine. And when these energy drinks first came out, ER saw increases in patients coming in with chest pain, tachycardia, supraventricular attacks because they were drinking all these energy drinks. So you have to really be careful with that. I know if I gave up my Coke Zero for Lent, and I made it 4 weeks, and I didn't have any caffeine. And when I was at my sister's, sitting with her, I just had to have something to stay up. And I found one of those little energy drink things. I thought it was an armor, body armor or something, I don't know. Oh my gosh, that was just something. Because I hadn't been drinking my caffeine, and I kind of cleansed my body of it. When I got that drink about halfway down, I thought, oh, this is a bad idea. We are going to start off talking about alcohol because it's just fun to talk about. And it's probably the most prevalent that all of you have been exposed to at some point. No, this is That's just fun to do now.
Karaoke.
Okay. No, y'all haven't done any of those things. Never. So alcohol is, pretty prevalent in our society, and tolerance develops pretty quickly. Like I said, you see alcoholics coming in with these high blood levels, yet they're walking around. You're going to have to take care of patients at some point. The patient who got in their car and hit somebody and killed them, and they're perfectly fine. Or they've got a broken leg, and that's tough. And especially depending on the little bag of rocks you carry around with you, that can be a toughie. But our blood alcohol for Alabama DUI is 0.08. But you can also get ticketed for buzz drinking now, 0.01 to 0.07. That's pretty much one drink, one glass of wine, one beer, one alcohol. So be sure you take some time.
That's the same charge as DUI?
I don't know if it's the same, but they can stop you, and if you test out buzzed, they can take your license. I mean, it's very similar. I don't know what the fines are. But yeah, so. But you're impaired. I mean, you are. You probably don't think it. I have never thought I was impaired when I got in the car, ever. But looking back, when I was in college, I think, dear God, thank you for getting me through college. Because you don't think that. And alcoholism, becoming an alcoholic, is not something that happens overnight. Nobody gets old enough and says, I think I will be an alcoholic. But you do go through some phases where, and usually it starts either with something stressful, getting started, or usually just having fun with your friends. Peer pressure. Just you're an occasional drinker, but you suddenly become that drinker at the party when everybody else is stopping. You're having a couple more. It's not time to go home yet. I want another one. I want another one. You are probably a stress drinker, like, I just drink to relieve stress. I can quit anytime I want. And maybe you can, but a lot of times that is starting down the path of abusing that substance. And as they move into, your book has pre-alcoholic, that's that little bit heavy drinker, big party person. And then early alcoholic, you're now having some times where you might have blacked out because you don't really remember what happened last night. Or you woke up with something you weren't expected to wake up with. You are drinking an eye-opener in the morning because you developed a tolerance. And your body just doesn't feel right if you don't have a little something going on. Or you are feeling really guilty, sneaking around drinking. But even though people are annoying you talking about your drinking, you still do it. Okay. In the crucial phase, you basically have lost control and you are compulsively drinking. You may try to cut back, but it doesn't work. And this is where your body starts to have those physiological changes that alcohol causes to our bodies. Now, critical, and then we get into crucial or chronic alcoholism. And those patients, a chronic alcoholic has no control. They will go into DTs pretty quickly. They can hallucinate. They are strictly worried about what they're drinking. They don't worry about what they eat, their nutrition, or anything that's going on around them. That between this early alcoholic phase and that crucial phase, before we get into chronic, we got a window of time there where their body has not started to physically deteriorate yet, and rehab is important there. But unfortunately, you can put somebody in rehab as many times as you want. If they are not convinced that they have a problem and do not put the work in to get ready to overcome their problem, if they're just doing that rehab and that intervention to make you feel better, they're going to be right back where they were. It's not going to work. And that's pretty much with any substance use disorder. That's one of the big things. You cannot do it for them. And it's very hard for them to understand at that point. Major losses between that crucial and that chronic phase, and then on into the chronic, major losses occur. They may have lost their jobs. They may have lost their families, but they continue to drink. In that chronic phase, they will have withdrawal, psychosis, and their body will start to fight them, because alcohol is metabolized into a substance called acetaldehyde. It's a poison to your body, and it affects every system in our body, especially the liver. And the liver does a ton of stuff for us. So when it can't work, that's a big problem. Now, I don't know where else to put this slide, but getting a good drug history and assessment on your patient if you suspect some type of substance use is important. This CWA is actually used when we are detoxing. We'll talk a little bit more about it, but it's not used until you have a patient coming in alcoholic and we're detoxing them and supporting them, and I'll talk more about that in a minute. The mask and the cage are two assessments that can be done to see how much and help the patient see what kind of problems they have with alcohol. And I like this cage for you at this level to really understand, because it's easy. This is a little checklist and stuff. It's in your book if you want to look at it. Cage is easy. Have you cut back and it not worked? Do you get annoyed when people talk to you about your drinking? Do you have guilt about the drinking it. You might be sneaking it, have a little eye opener in the morning, got your little glass of water, which is actually vodka, sitting over there by the TV. But you have some guilt, but you're still doing it. And number 4E is, do you need an eye opener? Do you feel better when you have that little shot of vodka in the morning? And if they're answering yes to these questions, then that's a good way to lead into, okay, let's talk about alcohol and why it's so hard for you to cut back, because your body's developed a dependence on it. Why is that eye opener? Because your body's developing a dependence on it. So that's a good way to segue into that talk with your patient. Now, as I said, the liver takes the brunt of this. And this is a healthy liver, and this is a cirrhotic liver. And what happens is, as that liver gets hit over and over and over again, it eventually will scar and get hard, and it can't do its job. What is the job of the liver? Okay, it metabolizes drugs. It cleanses the body of bacteria. It is involved with hemoglobin, hematocrit, red blood cell production. It helps with white cells. It stores a lot of blood for us. It is involved with platelets, clotting factors. It helps make clotting factors so we don't bleed to death. It helps with digestion of foods, fats, carbohydrates. And when we have a cirrhotic liver, it can't do any of that stuff. Okay? There was a great show yesterday. Last night we were watching, y'all don't watch TV, but I watch Bull. That's one of my few TVs I watch. And they were defending a lady that was accused of murdering her lover's wife. It was complicated. And she went to meet the boyfriend at his beach house and got there early, and he got there late, and the wife had found out about it, so she was waiting for her. And the girl got there at 4:45 and says there was a big argument, yes, but I left at 5 after and she was alive. Or no, she left at 4:45 and she was alive. And then the husband got there at 4 after, and he said she was dead. And she was laying outside with a stab wound, bled out. Well, when all this comes through, she is crazy as a loony bird and has stabbed herself in order to make the girlfriend look guilty and get her husband back. Unfortunately,
It did not work out.
yeah, no, it didn't quite work out for her because she had cirrhosis of the liver and she bled to death in 30 minutes. She exsanguinated. So I thought, we were sitting there watching it, and they were kind of coming up with this idea, and I was like, oh, she's got cirrhosis. Because they started talking about how she bled out so quickly, and so I was just been looking over all this and thought, yeah, so clotting factors really affected. So we're going to go through these kind of quickly. They're in your book. I also have Miss Wynn, very nicely, a couple of years ago, made a little list, which I have put up, that, tells you what happens to your body with cirrhosis and why. So that acetaldehyde, as I said, is a poison. And it attacks your nerves, and you end up with peripheral neuropathy like you have when you are diabetic. Tingling, not a pleasant feeling. You also have alcoholic neuropathy, which attacks your muscles and starts wasting away your muscles. And we see acute happen after a binge weekend. When I was working the ER, we always saw people coming in after New Year's, increases in those kind of things. And your CPKs go up, those muscle, because it's breaking down muscle. So you get a little rhabdo, and well, as that chronically goes on, you end up with chronic, and you don't have as much pain, and you don't see the CPA going up, but what you see is the typical what you see in an alcoholic. Little bitty skinny legs and arms, big old belly, ascites. But those little bitty skinny legs are because they're breaking down their muscles. Yeah. So, although I'd like to have skinnier legs, I don't want it to happen that way. That's not a good way to do it. So another big thing that happens is they don't eat. Their nutrition's terrible. Our liver is not storing vitamins, minerals. So vitamin B deficiencies, thiamine, they end up having what's called Wernicke's-encephalopathy. They can die from this. And it usually goes along with Korsakoff's. And I see that before you'll see the Wernicke's. And the Korsakoff's is kind of related to those blackout things, but they call it confabulation. They have memory loss. I mean, talk to somebody on the phone one day, and 2 days later the person's like, hey, I didn't really like that conversation the other day when you said blah, 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 blah. And they'll start going, whoa, 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 I didn't say that. I remember that conversation as a nice one. And da, 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 and they'll make up something. They truly believe that's what happened. And both of these come from that thiamine deficiency. So there's several things, because we don't get these patients don't have good nutrition. If they come into the hospital for anything, and we know they are chronic alcoholics, we try to boost them up. We check their H&Hs. We give them, it's called a rally pack, banana bag, that yellow bag of fluid you've seen patients get, that's got thiamine and all kind of vitamins in it to kind of get them boosted up until, because we know they're going to leave and not eat well. Also affects the heart. They accumulate lipids, and that heart will get large, thick-walled, and weak, and they have eventually end up with congestive heart failure, and they'll have arrhythmias. And we treat it just like we would somebody with congestive heart failure and arrhythmias, because that's what they've developed. Esophagitis, gastritis, both of these occur because that acetaldehyde, the alcohol itself is an irritant, and they're doing a lot of vomiting a lot of times, so that's an irritant. And they even will end up with, they have an increased incidence in ulcers, duodenal ulcers. And what if you have that ulcer and it perforates? They can bleed out pretty quickly because they have no clotting factors. They don't clot very well, so they'll bleed out. So the nerves are affected, our muscles are affected. Come on. Do this to me. Our brain is affected, our heart is affected, and the pancreas, the gastric and our pancreas. Okay? So all of these things that are going on, you know, they end up with diabetes or high blood glucose levels, or low, can go either way. And they also can develop alcoholic hepatitis, which comes from long-term heavy use. But the big one is the cirrhosis. And that's where our chronic alcoholic is headed. Okay? As I said, it gets so fibrous and scarred that we can't really do anything. The liver can't do its job anymore. So think back to A&P and the portal system, portal venous system, and our portal vein, which collects blood from the GI system and takes it through the liver for that first pass. Cleans out bacteria, helps to metabolize drugs. So if a drug is highly metabolized in the liver and that liver is cirrhotic, are they going to have more or less of the drug available? More. And they can get toxic. If you've got a highly metabolized liver drug that's metabolized in the liver, then, and it's cirrhotic, then you have to either cut that dose or, really watch your patient for toxicity. So we made that first pass, and it can't get through there. So that portal vein,
That was mine.
okay, it sounded like it came from over there.
No, I be setting alarm at 2:30 to go pick my son up from school when I'm not in class.
Okay. So think about a hose. If we put our thumb across the end of it, it makes it squirt out hard, right? So it's kind of like that liver is stopping that blood flow from getting through there because it can't get through that liver. So the pressures are going up. And when the pressure goes up and we're not making good protein, so remember what happens when protein's not in our circulatory system? That fluid shifts where? Out of the vessels. In this case, because that vessel is in our abdomen, whoosh, that's where the ascites comes from. It's all shifting out in that abdomen. So there is a procedure where they will go in and shunt the blood around the liver because the liver's not working, and that helps because those abdomens can get really big. That procedure is a TIPS, transjugular intrahepatic corticosystemic stenting. Y'all got it? TIPS. But that's what it's doing. If you think about the problem, then it's going to shunt that blood so that instead of going into the abdomen, we're going to move it around the liver. Of course, it's not getting any metabolism going on there, but it at least helps with that ascites. So, the spider veins here collect out here from the high pressure. That abdomen gets huge. It's a collection of fluids, and what can we do about that? Y'all ever had a patient come in with a big old abdomen like that? Josh?
Yeah, paracentesis.
Paracentesis. We got to get that fluid off of there. And it can be as much as, I've seen 6 liters pulled off of somebody. What would happen if you had 6 liters of fluid on your abdomen? Can't breathe. All right. And that portal hypertension is just going to get worse and worse. And the only thing that's going to help decrease this, they stop drinking. Unfortunately, that usually doesn't happen. So we see them over and over again back in there. Now another thing that happens, and it's because of that high pressure that's developed. The veins in our esophagus, the vessels, the vasculature here, the walls are not as strong because they're smaller. But they come right off of that portal vein with all that high pressure. And so they develop these little out pouches that are called varices. They look like little aneurysms. And unfortunately, I don't know why this picture will not show up well here. But that is a great scope of a esophageal varices. There's several of them in there. But they're just little out pouches in there. Now, our guy doesn't clot. And those vessel walls are not very thick. So, you increase that pressure, or you swallow something hard and rough, you can rupture one of those and they will bleed out quickly. I worked ER for a short time when I was a student, and I saw a guy, it's kind of like The Exorcist, except instead of vomit, it was blood that went across the room. Those high pressures, and the lack of clotting will do that. And they have to go in and use a balloon that will put pressure to try to stop it. They use cold fluid to blow that up so the vasoconstriction occurs, or they take them to surgery and ligate them. My guy got to surgery, got to ICU, and the next day blew out another one and he died. He bled out the next day. He had a lot of them in there. All right, so hepatic encephalopathy. Now this is caused because our liver helps to convert that ammonia, that protein, when we're metabolizing creates, it helps to convert that to BUN, to urea. But it can't do that right now. So our ammonia levels go way up and they get confused. They have that asterisk where they have the flapping of their hands. Their thinking is very off. They can't make decisions, not logical. And what do you know what we treat high ammonia levels with?
It makes you poop.
Makes you poop. Yes, it does. Lactulose. Yes. And it does make you poop. And I was so proud early on when I started doing clinicals, one of the students knew all their meds, did a great job. And they were holding the lactulose because the family told them, and she knew the patient had been having diarrhea all morning. And his hiney was getting kind of a little red. I said, well, that sounds like a great idea. But you need to go back and find out why is your patient on this drug. It's one of my soapbox things. This is why you have to know that. Her patient was not on that medication for constipation. Her patient was on that medication because his ammonia level was like 69. And we could not stop that drug. We had to do something else for the diarrhea and cleaning up his hiney. So she came back and was like, oh, I got it now. You know, he's an alcoholic. I said, yes, he is. So, knowing that. But other things anything that increases your protein, because then you're going to have more ammonia, like infection, hypovolemia, hypokalemia, GI bleed. Those can make those ammonia levels go up. Now, we've talked about most of these. I'm not sure that page number is correct. It would be from the MedSearch book. I think that's an old one. So I'm not sure. It had a total dedicated area for cirrhosis. I don't know that this edition does. But I do encourage you when you look at these and that sheet Ms. Wynn gave us to know. Why is it not only just say, okay, elevated ammonia. If you will understand, why does my ammonia level go up? Why does the ammonia level go up? We just talked about it.
It's not being converted to
Right.
urea.
The liver's not converting it to urea. And where does ammonia come from? Breakdown of protein. So what else could I do to his diet that would help bring that ammonia level down?
Increase the protein.
Decrease the protein. It's a little tricky because we need protein. No. So if I know that, then it'll click better if I got a list of these are some things that happen with cirrhosis. If I know, then I start thinking, okay, the body, the liver with cirrhosis, it's not working right, does clotting, so they're going to bleed more. They're going to be more prone to infection. So we're not making good leukocytes. This fetor hepaticus is the ammonia breath they develop because their ammonia levels get up so high. These spider angiomas are from that increased portal hypertension. Those big old veins on their belly. Vitamin deficiencies. Their liver's not storing it and they're not eating. Okay? So understand not only, don't try to memorize that, understand the patho behind it and that'll come. These are three of the biggies. These patients are anemic. They have low red counts, which means they don't. Just checking. Which means they don't have good oxygen supply. So let's look at our post-op patient. More prone to infection, not going to heal as well, and hemorrhage will bleed out quicker. Sometimes we can't do surgery on these patients until we tweak them up some. Get their fluid and electrolytes stable, their ammonia levels down, their RBCs up, and then try to operate. Dusty. Also affects every system, guys. It just is going to end up deteriorating your whole body. How can we fix it? How can we help cirrhosis? They got to quit drinking. No alcohol. That's it. We cannot get back the liver we have lost, the cirrhosis. Our liver can be damaged to a certain extent. You've probably heard of people that have a contusion of their liver and they took out a small portion and it grew back. Yeah, a healthy liver. But once it gets cirrhotic, we can't get that back. It's like those nephrons we lost. We can't get those back. But we want to keep from getting, that's why we want to catch them early on before they get into that chronic alcoholism. So once they're there, we're going to treat that high blood pressure, just like we would a heart patient. Low sodium, blood pressure medicines. Oops, sorry, something else I wanted to say over here. We may use diuretics to get some of that fluid off, help with the ascites, and decrease the edema that they develop from the portal hypertension. The banana bag I talked about, the replacement of thiamine, B complexes, mag sulfate, because as they're detoxing and coming off of that alcohol, remember they had that rebound CNS stimulus, and mag sulfate will help to calm that nervous system down, the irritability. Antipsychotics are important because they will have some psychosis, hallucinations, they may need sedation, but our goal is to decrease that physical need, to watch for DTs, and this is where the CWA is going to come into play. Because it will tell you, are we needing to go ahead and start some Ativan here? Now, I got my slides a little mixed up here. I need to move them, but we'll get to that in just a minute. So, when a patient is detoxing, we're supportive, okay? We're trying to fix all the stuff. Fluid overload, safety, because they can get DTs, they can fall. Keeping their blood pressure down. No vigorous physical exercise or hard candy because of the varices, that's right. The cool or warm water, their skin gets very dry, has those toxins on it, it gets itchy, and we want to help with that. Now these are my slides I got in here wrong because we've been talking about detoxing. So now we want to look at just these few slides and then we'll go back to detoxing. When a patient has detoxed, come off their alcohol, they're physically good, and they've decided they want to go to rehab, there are some things we can do to help them. If they have a real hard time staying off the alcohol. One of them is a really old drug called disulfiram, and I think people used to slip it into their coffee, but it's really not a good idea. Because what this drug does, when you consume alcohol when you're on it, the drug blocks that acetaldehyde metabolism stuff. So they get drunk and they stay that way, and the acetaldehyde is also what makes you, well, I call it commode hugging drunk. Okay? The nausea, the nausea, the hypertension, So that's what happens on this drug. It makes you sick as a dog. So the idea is that, oh, I'm not gonna drink that again. It's a deterrent. The naltrexone is a drug that we see used with withdrawals from heroin that helps decrease cravings. But they've also found it to be effective with alcohol. So if you drink, let's go back to that disulfiram. If that person drinks, they get throbbing heads, hyperventilating. Think about when you've been drunkest and sickest from being drunk. All these things happen, and this happens quick on that. And it's a reaction with the alcohol, and here's the catch. It has a long half-life. So you can't get a party invitation on Wednesday and say, oh, I'll quit drinking tomorrow, and I'll quit taking that drug tomorrow, and I'll go to the party Saturday. You're going to get sick. Because this drug hangs around for 3 to 4 weeks. And you drink any alcohol, you're going to feel it. The other thing is that it's not just alcohol and bourbon or beer, it's alcohol and vanilla extract, alcohol in mouthwash, shaving lotions, any kind of alcohol will make them sick. Okay? So they have to actually, you have to educate the person, and they have to sign a consent form. I know what happens if I take this, and I know it has a long half-life, and I know I have to be off the med for 3 weeks in order to have any type of alcohol, and that it's not just. So that drug is, I mean, if the person is deterred, easily, that can work for somebody. But they have to know. They have to have a informed consent. Campbell is a fairly new drug that is also used in conjunction with counseling, and they think it helps through the GABA system, which again is our neurotransmitters. So, and all of this stuff, you can't just say, okay, here, take some disulfiram, get off don't drink for 4 weeks, and you're good to go. But all of this is combined with counseling. Because generally there is, people use alcohol for stress, to cope with things, and they've got to learn another way to do that. And that's what you learn in rehab. All right, go back to we're detoxing somebody. I gotta fix this. Benzodiazepines that rebound CNS stimulation. This is where the CWA comes into play. Benzodiazepines will calm that. And at some point, we need to give them, and your book has a copy of this, Alcohol Withdrawal Assessment Scoring Guidelines, or CWA. And you need to look over this and look at what it is assessing. I think they did this on your SIM, your alcohol SIM, if I remember. They look at, are they nauseated, vomiting, anxiety, having any visual disturbances, auditory, do they have headache? Okay, and everything is scored. And at a certain point, you say, okay, our score is high enough now that we need to go ahead and start the benzos. And depending on how high, it will tell you how much benzo to start with. Okay? So that's what that CIWA. Look at this and understand what kind of things you are assessing for. Because you're assessing for too much stimulation of the CNS, and you're trying to hold it down. Anticonvulsants, multivitamins, thiamine. We talked about these banana bags. It's that yellow bag that you've probably all hung, maybe didn't realize. It's full of vitamins and good stuff. We don't just give it to alcoholics. We give it to patients with big wounds or trying to heal or that are not progressing and need a little extra nutrition. Other things are, again, treating symptoms. slow the heart rate, or if they have antiarrhythmics, antipsychotics, anticonvulsants, things to decrease cravings. So friend, y'all know these drugs. All right. At 15 minutes, right, Jay?
Well,
3:05, it's 10:10.
you're right, you're right.
Thank you. All right, so Alcoholics Anonymous is a great support group, but it doesn't work if the patient doesn't understand what it's for, and if they only went to counseling for their family because somebody else said they had a problem. Most of the time that means that they don't think they do. All right, so we did say that alcohol is a CNS depressant. These are some mores, the phenobarb, resveratrol. The biggies, these anti-anxiety agents, are benzos. And when these first came out, they did not think they were addictive. And they were passing them out like candy to women who were having premenopausal depression and problems and anxiety, and then all of a sudden they're addicted. The other problem with these drugs is that most of them have a long half-life. And that means that if I've got 30 days of Valium sitting in my cabinet and I'm depressed and I get suicidal ideations, I can pop all that Valium, and it's going to be pretty hard for the docs to get that. If I don't get my stomach pumped pretty quick, once that gets into the system, the half-life is really long. And that's why Ativan is usually the one you'll see used, because it has the shortest of those. A big thing with these also is they potentiate each other. So if you've got somebody who's anxious or a little depressed and they're drinking, and then they pop their Ativan or Valium with it, it'll potentiate the sleeping, the respiratory depression. It'll potentiate those effects. When we look at withdrawals, these are CNS depressants. So when I'm coming off of it, they're going to have more stimulation type symptoms, the sweating, the increased pulse, very similar to the alcohol withdrawal. But these withdrawals on benzos, alcohol, you get them through that first, the big detox. Because of the half-life of these benzos, those withdrawals can take months. They can still be having withdrawal symptoms. All right, stimulants. Obvious, psychomotor agitation, everything's up. So when they're using, they can get tachycardic, think fight or flight. Eyes dilate, respirations go up, they get tachycardic. They have chest pain, they can have cardiac arrhythmias, and the withdrawal produces that crash, that severe depression, the exact opposite. And they have cravings, severe cravings with these drugs, especially meth. So we got your amphetamines, your non-amphetamine stimulants, diet pills, Adderall. Then we've got cocaine, probably one of the most potent stimulants. And we got crystal meth, probably one of the worst ones you can think about. And then we got our caffeine and our nicotine. And as much as I hate smoking, I do realize that, again, there is an addictive quality in our brain. It's not just do better with your impulse control. All right, so these stimulants produce, obviously, stimulation, and they hit different areas of the brain. This is when I was talking about some develop nail-biting habits or pacing, those kind of things. And it is a very potent stimuli, and people usually say they never have that first high that they had the first time. They're always chasing their tail. But the half-life of cocaine, and I think I forgot to talk about this morning, but the half-life of cocaine to 90 minutes. Okay? You know what half-life means, right? The half-life of meth, which is a very potent stimulator too, is 10 to 12 hours. And you can make it at home or from your meth dealer. You can get it from your meth dealer. They're everywhere. South Alabama actually has a really big problem in our rural counties because there's all kind of meth houses just hidden off in the woods in places. And it has become a huge issue. Any of y'all live in Geneva County? Y'all be careful up there. A lot of meth over there. And the other thing is, meth is, I was telling this morning that, you see them go into a meth house and they're all hazmat suit out. They're not just doing that for television because it looks good. It does, but makes for good television. But they do that in real life. Children who live in houses where meth has been cooked in the basement will test positive for meth. It gets on the walls. You might as well burn your house down if you were renting it to a meth head.
It would blow up sometimes.
Oh yeah, and they blow up real easily. That might be a better thing. Just blow the house up. Oh, it's been a meth lab.
There's been a lot of them in Jackson County in like the past year or so that's blown up.
Oh, man.
Yeah.
And usually somebody's standing there cooking, so. What was that show?
Breaking Bad.
Yeah. That was an interesting little show. Tolerance is common. Cravings, meth, bad cravings. And preventing that relapse is hard because they have that physiological crash and they will reuse in order not to have that. So if we're stimulating, we're tremors, restlessness, decrease blood pressures, heart rates, arrhythmias, dilated pupils. If they snort it, because you can snort it or smoke it, or they're going to have that little nasal rhinitis. And these are my repetitive behaviors. We treat as they're detoxing that to help them through that crash. They may need antipsychotics, the benzo. They're going to need things for the stimulation. If these patients come in with on-board overdose with CNS stimulants, then you better get a good heart and neuro because they can stroke from the high blood pressure and they can have an MI from the coronary artery spasms. IV fluids, treating their dysrhythmias. So at this point, with stimulants, if they come in intoxicated, you're treating what the symptoms become. These patients, as they detox on this drug, it's not like with the alcohol where we had that rebound and we really, they can seize and die. The biggest problem with these patients is that crash and depression. And they will get suicidal on you. Okay, I found this on the internet. Thought it might be a good little break. The county sheriff's department put the best things on the internet. I just love it. But they also have lists of all the meth users they've arrested. They have pictures of them, what they look like before they started using and what they look like after. And it's pretty sad. As I said, meth has a much longer half-life. It's easier to get. It's cheaper than cocaine. It was originally called the cheap man's cocaine. And to begin with, it will increase your alertness, decrease your appetite. You might lose some weight on it. But long-term use, chronic use, causes irritability, causes paranoia, and physical deterioration of your body. Meth is made with different components. One of them is some type of acid. It can be lye, battery acid, I mean, just crazy stuff. Would you really put that in your body if you were thinking correctly? And they develop tooth decay because not the acid eats away their enamel. And if you're a meth addict, that's what you do. And you don't eat a lot, and so they're not taking care of their mouth and their teeth.
Is that why they have that buttery looking teeth?
Oh yeah, I got some pretty teeth to show you. They will itch because those acids will start to leak out. They have hallucinations. They think there was bugs crawling on them. They're scratching. They get infections. Those cravings, very intense. Went to a meeting, and the lady was talking about meth, and her brother had been a meth addict. They got him clean, and he had been clean and sober for 3 years. She said he battled with those cravings daily. He could hear a song that he played when he did meth, and those cravings would start, or see somebody. And the other big thing they struggle with is depression. And he ended up committing suicide 3 years out because of the depression that occurs with that. So here's our guy picking at his skin. Here's meth mouth. This is those teeth that have just been, this is a serious case. And this is a lady who started back here using meth, and 10 years later, this is what she looks like. Now those county sites, and I need to get some more pictures. I just used that one because we used to do the skits, and I'd always have the meth people would always have their pictures, but I've seen them go from that top to that bottom in a year, 6 months. It doesn't take long for your body to start deteriorating. And this is just another, with stimulants, everything's speeded up. You have the dilated hypertension and all that. Let's talk opioids real quick. I'm going to run over a few minutes. But that's okay, isn't it?
There's a minute, there's a bonus point.
So opioids are what we use to help with pain. But unfortunately, we've developed an opioid crisis in this country, and it does cause our body. Respiratory depression is one of the biggest things. So they develop withdrawals also within 1 to 3 days. It depends on their last dose. Again, withdrawal is always going to depend on when their last dose was, how much it was, and how long they've been using. So the problem with these is that they are right there by that pain center, is right there by that reward center. So it's very addictive. In order to treat these patients when they're trying to come off, after they come off, to stay off, naltrexone decreases cravings. Now, if you overdose a patient in the hospital, say, this has happened, it's not frequent, but it's not unknown. Patient comes back from PACU, they've given him morphine, he gets to the floor, they move him around, he's hurting again, they give him more morphine. And next thing you know, his respirations are 8. So you go in there, shoot him with some naloxone, and the respirations go back up. I'm good. Go back to see your other patient. Come back in 30 minutes, your respirations are 4. This have a short half-life. It may take a couple of times to dose him. And that's usually what your order is. If you're in the field or in the ER and you have a patient come in overdose, not breathing, they'll use this. And you better step back because they wake up crazy. And you have to be careful with them. But it reverses the sedative and the effects of the whatever drug they were using, and pulls them out. They are now authorizing prescriptions for family members of heroin addicts, known heroin addicts, so that if they overdose, they can get them back. Because by the time they wait for EMT to come, it's too late. The other one way to help patients, we came up with suppressive therapy. Methadone was probably the first used. We have Suboxone, I can't remember the one that's on your thing, Norfovine, but they're less addictive. They act a lot like the heroin, but they don't, that they're not as strong. And if you use heroin while you're taking these, the effects are not the same. So the point of this was to get patients down off the heroin to a drug that was less addictive, and then start working on getting them off of that. The other point was, especially during the AIDS epidemic, when it first came out, was about the time these substitution drugs came out. They wanted to stop people from sharing needles. And they'd open these methadone clinics. They could come in, get their methadone, and not share needles, because that was one of the things passing AIDS around. And it helped. But the way this is supposed to work is that we wean off the Suboxone or the methadone, but I do see patients that have been on both those things for years. Not really the point of that, but okay, real quickly, hallucinogens. The biggest thing you need to remember about these is they can cause flashbacks. They cause your reality to be distorted. And a flashback is if I had partied with LSD 2 weekends ago, and I'm up here lecturing, and all of a sudden the clock starts going real fast, and all these crazy colors start coming in. I have distortion of my perception of reality. It's from, not because I went to the bathroom and did some more, it's because I did it 2 weeks ago, and this is a flashback. I can't control when it happens, and it just comes on. So that's one of the things you want to remember about that. And it causes the nausea, vomiting, pupil dilation, increase in pulse, increase in things. Cannabis. We're going to hear a lot more about this as more and more states legalize it. It's not legal in Alabama, but I do believe we can use medicinal, because I know I have used Marinol before in the hospital. It works really nice for cancer patients with their nausea. It helps with patients, epileptic children, you know. But there are problems to it as far as physiological things that happen. I don't quite understand why we're rushing to, well, it's not really a rush. I've been trying to do it for a long time, but they didn't. It's like if I pull you over, if I'm a policeman and pull you over, I can test you for DUI. I can't really test you for marijuana use. I don't know how much is too much and how much is too little. That's impaired your driving. You know, we didn't really put the cart before the horse here, I think, but I'm sure that'll come. And it can cause some paranoia, the cognition changes, elevated heart rate, dry mouth, munchies, those kind of things. One problem I've seen with it too is that the marijuana when I was in high school and college was totally different than this. This is some strong stuff. And you knew, you know, in the 70s, people knew if I buy from this guy over here, and then I buy from this guy over here, it's going to be about the same. Not now. There's not any regulation with it. I can buy the same stuff, the same amount, and overdo it with this one and not this one, because they really hadn't gotten that regulation down there. This just is, like I said, with when you're withdrawing, think those symptoms is the opposite of what the drug did. And the fact that you're going to be working with these patients at some point. and you need to start, thinking about it. The last thing has to do with changes that occur, like with our opioid or heroin addicts. They are not going to heal as well. They're going to have more post-op bleeding, complications. With our smokers, anesthesia is going to affect them differently. Any of these substances, misuse, the anesthesia can affect. They cannot wake up as quickly. We already talked about the fact that pain, trying to keep them out of pain is going to be different. And if I am back on my caffeine coats and I have to have morning surgery, when I wake up, you better have me some caffeine because I'm going to have a headache. Okay, you're same-day surgery patient. Treat their pain. Injury is not when we want to come off. We treat their pain, we get them healing, then we start worrying about tapering off of their drugs. Questions? So that's on 5.5 minutes.
In eternity.
Thank y'all. Do I see anybody
Not me.
this week? Well, then y'all have a good weekend.
Right, you too.
You're done. Y'all are done with me. I did not get to your, not y'all. No, they've already left. Sharon was left.
Get it out of here.
Yeah, I got it.